Bismillah ar-Rahman ar-Rahim. Good evening, everyone, and Ramadan Kareem. This is Haidar Yahya again, the marketing manager of Asino in Iraq. On behalf of Asino and its team, we'd like to thank you for attending this second session of our webinar. Many thanks to Department of Obstetric and Gynecology, College of Medicine, University of Basra, represented by Professor Ali Faleh, for giving us the opportunity to sponsor such amazing event. We also thank our esteemed speaker, Professor Rahim Haloub and Professor Ali Naqash and Dr. Ali, for their time and effort to enrich our session. If you have any question during the session, please type it in the question bar and we will have a question and answer session after the presentation. Now I leave the speech to our esteemed guest, starting by Professor Ali. Professor Ali, the stage is yours.
Thank you very much, Dr. Haidar. Bismillah ar-Rahman ar-Rahim. الزميلات والزملاء الأكارم. السلام عليكم ورحمة الله وبركاته. On behalf of Basra Medical College, it is our pleasure to host you in this webinar, and with our deepest thanks to Professor Rahim Haloub and Professor Ali Naqash from the Royal College of Obstetricians and Gynecologists for their participation in the webinar we did yesterday and today. Many thanks for Asino Company for sponsoring this webinar. The program for this webinar is going to be about updates in hypertensive disorders during pregnancy, and there is a third lecture to be presented by Dr. Ali Mahsen, who is the medical manager from the Asino Company about UTI in a pregnancy. The last 15 minutes of this webinar is going to be for discussion, and after that we have a closing talk from Dr. Haidar again. The first speaker is Professor Rahim Haloub. He is working now at Basildon and Farouk University Hospital in London, and he is an honorary professor at Basra Medical College, and he is going to cover the first part of what is update in hypertensive disorder. Mr. Haloub, please.
Thank you very much, Ali. Very kind of you. And of course, I thank Haidar for his effort and hard work for organizing the webinar, and Ramadan Mubarak. And we are going to start the session about the hypertension during pregnancy and the updates, the recent updates. I need to go a little bit. Right, okay, and everybody actually knows about, we are very familiar with the incidence of hypertension and the definition of each part of the hypertension during a pregnancy. It actually contributes to about 10% in a pregnancy, and classified into 4 categories. Chronic hypertension, when the diagnosis of hypertension in the early stage of a pregnancy, and then PET or preeclampsia, and preeclampsia complicated on the top of the chronic hypertension, which is diagnosed already. And the new entity, in fact, there is a change in the name of the PIH to gestational hypertension, which actually reflects very well that the hypertension developed during the latter half of the pregnancy. Now, I'm actually sticking to the NICE guideline now. There is a recommendation written by guideline long time ago, but updated in 2019, October, November. And in that recommendation, there are a lot of change, and then we need to be very careful to actually follow these changes. There's no longer classified as a mild, moderate hypertension or severe hypertension, but there are 2 classifications according to the level of the hypertension. 142 over 90 to 159 over 99, or a severe one, hypertension more than 160 over 110. Not only that, there is a change in the target blood pressure. Target blood pressure meaning that above that should be treated, 135 over 85. And other recommendation, the aim, not only during pregnancy, but when you discharge the patient, it has to be on single therapy rather than multi-therapy. Or if you cannot control with blood pressure with the single therapy, then you probably can follow the NICE guideline on the adult hypertension. I'm sure Ali Naqash will touch on that when it comes to the treatment. Delivery before the recommendation to deliver at 37 weeks is not actually indicated if the blood pressure not very high and well controlled. And even with regard to advice on the breastfeeding, now that changed now. All the antihypertensives is not actually contraindicated for breastfeeding. Now, in addition to that, NICE actually introduced a PIGF, placental growth factor, based on testing to help rule out preeclampsia, meaning that in the prediction, which I'm going to touch on it later on, and also introduce telephone app you can download. In fact, not you, the patient can download and put in the symptom in order to predict the complication with the hypertension or during a pregnancy, and I will touch on it later on. And therefore, here we are. That's a very simple look at slide to identify the major hypertension and the level. And of course, they put the HELP syndrome identity or entity within the preeclampsia as part of the preeclampsia rather than separate entity. And of course, mentioning the complication which can actually happen with regard to the proteinuria, CPR, and thrombocytopenia, elevated liver function, pulmonary edema, and cerebral and visual symptom, and of course later on renal and other problems which we are going to review. Now, the implication of the hypertension during pregnancy is on the mother and the baby. The maternal mortality increased, and in the United States, maternal mortality 7.5% of maternal death due to hypertension and the complication of the hypertension. Now, in addition to that, if a patient had hypertension before pregnancy, the chance of that patient to develop GDM, the gestational diabetes, is about twofold. And moreover, if you look at the transient hypertension, again, there's an implication for that. And the patient who manifests that late in the pregnancy might actually lead to development of chronic hypertension later on after delivery. Now, in general terms, the hypertension occurs in about 22% of women of childbearing age. The prevalence depending on few factors like age, race, and body mass index. And if you look at the population-based data, indicated that 1% of pregnant women complicated by chronic hypertension, comparing to about 5% in general due to gestational hypertension without proteinuria, and about roughly 3 to 6% due to preeclampsia. There is no evidence that pharmacological treatment of mild hypertension reduce the incidence of preeclampsia in any population. However, this is actually debatable. One scientist, McGee, looked at about 1,000 women between 14 weeks and 34 weeks, and trying to, with the blood pressure, mild blood pressure, and trying to find out with two regimes, tight regime and less tight regime. And he found clearly that with the tight regime, the control of the hypertension tightly prevent PET comparing to less tight regime. And remember one thing which is very confusing, that the blood pressure during pregnancy, it actually goes down by about 10 to 15% over the first half of pregnancy. And most women with mild chronic hypertension, mild meaning 140, 60 over 90, 100, decrease in the blood pressure may not require any medication. That means a woman on medication before, when she is pregnant, she might not require medication. But these women should be monitored very closely. What about the pathophysiology? Without actually complicating the issue, pathophysiology is a multi-organ endothelial dysfunction, meaning that anything with the circulation anywhere in the body is affected by the endothelial dysfunction, and that leads to contraction of the smooth muscle and lead to the narrowing of the caliber of the arteriole. And that's observed in the preeclampsia, anywhere in the body, brain, kidney, liver, lung, and heart, and the placenta. And due to that, there's the development of edema, microinfarction, and microhemorrhages in all gestation, in all organs. Of course, the degree of it, depending on the degree of the blood pressure, depending on the duration of the preeclampsia, whether the preeclampsia started early or late. Now, what about the main issue here about the effect of that on the placenta, because the placenta is a vascular organ. And due to the endothelial dysfunction, there is increase in the clotting factor, and in addition to vasculopathy, incomplete growth of the decidua, affecting the spiral artery invasion of the decidua and the myometria. And this reflects on the baby, of course. That will lead to reduction in the uteroplacental blood flow, and that will lead, of course, to change in the fetal growth and fetal heart, and that will lead to non-reassuring fetal heart, affecting the biophysical profile and leading to oligohydramnios and fetal growth restriction. In the kidney, it might lead to the endotheliosis might lead to increase in the leakage of the protein, and it might actually continue to cause acute tubular necrosis or even cortical necrosis in the kidney. Now, until now, nobody actually claimed that we know the pathophysiology of the preeclampsia, and I mentioned the endothelial. But there's evidence, in addition to that, there's an indication that there's altered maternal immune response to fetal placental tissue, and that contributes to the formation or the triggering of the preeclampsia. Now, if you look at the on the left, you have non-pregnant spiral artery. On the right, you have the normal pregnancy spiral artery behavior, with the widening of the diameter, normal development of the endothelium, reaction, the smooth muscle and everything is different from comparing to the middle of the picture of the preeclamptic spiral artery, with narrowing of the diameter, and that will lead to reduction in the blood flow, in addition to reaction around that one, indicating, if you look at the even the smooth muscle here, there is a huge growth of smooth muscle, which lead to the contraction and reduction of the blood flow, and of course the T changes affecting the endothelial lining of the spiral artery, and the reaction of the deciduous to it, and the reaction of the smooth muscle to it. But if you look at that effect, it's not actually unique to one factor. There are actually many factors contributing to the formation of the dysfunction of the spiral artery invasion. There are oxidative stress. There are other things which might be a genetic factor, and there is the NK natural killer that contribute to it, in addition to maybe placental growth factor, which we are going to touch on it later on, leading to dysfunction of the placenta, leading to the intrauterine growth retardation and multi-organ dysfunction in the woman. Now, I actually put down here a picture just to remind you that I'm going to talk about the role of angiogenic biomarker to predict preeclampsia, which is very important, and the NICE touch on it, and now it's a very important issue in order to share with the patient and try to warn the clinician about the chance of that patient to develop preeclampsia. That's another picture, which is a very nice picture, showing you the amount of reduction in the blood flow if you compare the normal pregnancy on the left and the preeclamptic pregnancy on the right. On all aspects of the spiral artery invasion, from the myometrium to the decidua to the placenta, there are changes which actually affect the blood flow and huge reduction in the blood flow. If you look at the thickness of the endothelium, in addition to the thickness of the smooth muscle around the artery or the spiral artery, you can actually judge that there is something which can activate it in order to narrow the the channel, the diameter of the spiral artery, and that will lead to the dramatic reduction in the blood flow. Therefore, we know that there is a multi-organ dysfunction. That multi-organ dysfunction leading to maternal syndrome and fetal syndrome, or combination, both maternal and fetal syndrome at the same time. Now, with regard to the chronic hypertension, it's defined as blood pressure exceeding 140/90 before pregnancy or before 20-week gestation. When the hypertension identified during woman pregnancy, she is at least less than 20 weeks, and blood pressure elevation usually represents chronic hypertension. However, you have to apply standard of blood pressure recording, and I will come to that in a minute. Now, with regard to the chronic hypertension, you know very well that it could be either essential hypertension, which is 90% of it, or maybe in about 10% due to secondary things, which can actually be kidney origin, or originated endocrine origin, like pheochromocytoma, hyperthyroidism, hypothyroidism, elevation of the growth factor, growth hormone, and hyperthyroidism, parathyroidism, and co-irritation of aorta. In addition to that, there is something suggestion that a woman on oral contraception prior to the pregnancy might actually be a risk factor for development of hypertension when she is pregnant. Now, about 20–25% of women with chronic hypertension will eventually develop preeclampsia during pregnancy. Now, therefore, the important task of the clinician is to find a way to differentiate and to diagnose chronic hypertension or preeclampsia. And it's challenging. It's not that simple at all, especially when the patient comes maybe late or late booking and maybe not actually giving a perfect history, but definitely a combination of things you can employ in order to find out whether you are dealing with chronic hypertension or preeclampsia by also involving laboratory investigation. Now, if we compare the preeclampsia with hypertension, the vasculature of normal women typically affected by the angiotensin II and epinephrine in addition to other peptides. But during the pregnancy, the effect of these peptides on the arteriole will be lower, and therefore to allow hyperdynamic circulation of the blood. Therefore, we know during pregnancy, that's why we have a lower blood pressure. I mentioned before that the blood pressure lower by about 10 to 15%. This is due to the effect of the less effect, the angiotensin and other peptides less effective when in a pregnant woman on the smooth muscle. We don't know why. In the hypertension during a pregnancy, due primarily to the constriction of the arteriole, and that will then lead to reduction in the intravascular volume. Now, with regard to the preeclampsia, it's on the other way that the effect of the peptide on the arteriole will be augmented or altered. And it might actually, that alteration of the effect of the peptide on the arteriole might actually come even way many weeks before development of hypertension or preeclampsia. But the question is, the blood pressure of a preeclampsia is labile. Labile meaning that up and down. And therefore, the effect of the peptide might be on and off maybe. Not only that, but if you look at the behavior, the rhythm, the day rhythm of the blood pressure, it's actually blunted or maybe reversed. Now, the effect of the blood pressure on cardiovascular system, that's part of the multi-organ dysfunction. That actually showed that home and ambulatory blood pressure measurement are increasing being used in pregnant women because we rely on the midwife in the community to measure the blood pressure. But one important that we have to assume that all the measurements should be validated, meaning that the instrument, the equipment you actually choose should be validated, because sometimes you might actually measure the blood pressure with a wrong equipment, and that indicates high blood pressure or even low blood pressure. A patient with preeclampsia might be recorded as normal. Rapid weight gain, again, it indicates pathological process, and it warrants investigation, not only waiting for the blood pressure to be elevated to say that we are dealing with preeclampsia. And remember, due to part of it may be a little bit of reduction of the blood pressure early in pregnancy. In addition to that, when we never allow now women to have her blood pressure recorded when she is actually supine, lying down. She is actually on the chair, sitting in the chair, and for 5 to 10 minutes, and we do the blood pressure in order to avoid inferior vena cava compression, and that's very important to avoid in order to record the blood pressure accurately. Now, what about the risk factor? Of course, you are familiar with the risk factor of a primary gravida, new partner, multi-gravida with a new partner, age between 18 and 35, and history of a preeclampsia in the family and in the patient in a multi-gravida, And of course, black race, we will come to that, and overweight, the BMI above 30. And if the pregnancy duration between the two pregnancy less than 2 years and longer than 10 years. All these are risk factors for preeclampsia. Now, with regard to the individual risk factor, if you look at the maternal age, the less than 18 and more than 35, we can actually understand the 35 due to the comorbidity after the age of 35 with the high blood pressure. That might reflect on the frequency of PET during the pregnancy. Black, very well known, especially in the UK. We can actually, because we can compare them with white and Asian, and they are actually not only just more frequent preeclampsia, but difficult to treat. And sometimes we might require multi-agent therapy in order to control their blood pressure. It's very, very hard to control the blood pressure in a patient, in an African lady with preeclampsia. Women who develop preeclampsia, overall risk of a future preeclampsia about 18%, and it is higher if you develop preeclampsia before the first before 27, 28 weeks. And these particular women will have increased chance of cardiovascular problem later on in life. Now, again, the risk factors continue, and I mentioned a few other risk factors, and you are familiar with it, like diabetes, both type 1 and type 2, and lupus, thrombophilia, migraine. But in addition to that, we have the placenta fetal risk factor that being generated from that, like in multiple pregnancy, twin, comparing to singleton. A baby develop hydrops fetalis will actually, a woman will have, the mother will have higher chance of preeclampsia. And GTN, don't forget GTN, had it for mole and triploidy. Now, a woman with the blood pressure or high blood pressure or preeclampsia, antenatal appointment, normally, if it's well controlled, we actually see the patient between 2 to 4 weeks. And we pay more attention to the diameter of the cuff. We have to measure, if we are in doubt, we have to measure the mid-arm circumference. And if it's more than 35, we use the large cuff. And we have a small cuff, we have intermediate, and we have a large cuff. So therefore, measurement, because if you use a small cuff on a big lady with a high BMI, it will actually give you different reading and false reading. And how to measure the blood pressure? I mean, we take it lightly to put the cuff and measure the blood pressure without thinking. But in fact, we have to look into it very carefully. Of course, the measurement, depending on the sound, cortical sound, and we have 1 to 5. And we measure the blood pressure on the number 1 and number 5. But 5% of women might have no gap between 4 and 5. And therefore, the blood pressure should be written 120 over 80 over 40, meaning that the cortical 1, cortical 4, and cortical 5. So basically, that indicates that probably for that woman, the blood pressure measurement, you have to pay more attention to measure her blood pressure accurately. Now, and remember one thing, that we never actually use now electronic one. We actually use the manual blood pressure. This is the European recommendation. The sphygmomanometer we use, and no electronic blood pressure measurement in the UK. Now, what about the prediction? And that's the new theme from the NICE, how we predict the PET or preeclampsia. The NICE guideline introduced PIGF, which is the placenta growth factor. And that actually helping to rule out preeclampsia in women presenting with query preeclampsia. And the PIGF is a molecule or a peptide and contribute to the angiogenesis and vascular angiogenesis and embryo during the embryogenic stage. The main production of the PGF is coming during pregnancy from the placental trophoblast. Therefore, it will reflect the activity of the trophoblast. And also, the PGF can actually affect the behavior of the villi. So therefore, the growth of the invasion of the decidua and the myometrium is influenced by PGF in addition to other peptides. There are many other peptides will actually contribute to the development of the blood pressure, blood vessel in the placenta, and it's very crucial for the feto-maternal blood flow. Now, this picture actually giving you the a little bit of view about what happened in the placenta level, and with the production of two peptides here, that peptide, which is SF1T-1, and the PIGF. Therefore, if you look at the normal pregnancy, there's a reduction in the red one, and there's increase in the PIGF. While in the preeclampsia, there's a reduction in the PIGF and increase in the red one. And therefore, we are not only measuring the PIGF to indicate whether the patient will actually develop preeclampsia or not, but we are measuring the ratio between that and the PIGF. So therefore, a higher ratio is indicating a higher risk for preeclampsia. Lower PIGF indicate preeclampsia. Now, again, we continue with the PIGF for prediction, and so therefore there is a test available now to measure the PIGF, and the test will be available within about 15 minutes, and that will tell you whether the PIGF is normal or not. In the normal pregnancy, the PIGF level rise and peak at between 26 and 30 weeks. So when PIGF do not rise during pregnancy, there is an indication that probably this is due to the placental dysfunction, and therefore maybe development, maybe not definitely, but maybe development of preeclampsia later on. So therefore, to rule out, you check the level between 20 and 34 weeks. And that will actually give you the prediction. And the ratio, if you want to do the ratio will actually confirm that, because that involves other peptides also. Now, therefore, there's a table actually showing you how to interpret the PIG and the SFI-T-1 ratio. And as we say, that lower ratio in favor the preeclampsia, higher ratio in favor normal pregnancy, higher PGIF in favor normal pregnancy, and lower in favor preeclampsia. And there are two tables, one for the PIGF and one for the ratio. Now, of course, in addition to that, of course, we have to rely on the patient telling us about what is feeling, her blood pressure, her visual problem, putting on weight rapidly, all that due to the vascular dysfunction, which it can be anywhere in the body. Therefore, any change in the body, whether renal, brain, or anywhere in the body, it might indicate that this is probably leading to preeclampsia. Now, I mentioned the app, the telephone app, and I'm sure the Iraqi doctor will love that. There are actually two apps. One to that one full peer, or the PREP validated one. One of them work until about 34 weeks, and the other work from 34 weeks to full term. They are available in the App Store, and you can actually download it, and the patient will then put her feeling and alert the clinician for that, and then you can take action. Of course, the effects, as I said, that it's multi-organ, and therefore any organ can be affected, including the liver, with the development of tenderness in the upper quarter, right upper quarter, indicating there might be enlargement of the liver, or maybe subcapsular hematoma formation, especially when it comes to HELLP syndrome diagnosis. In the brain, of course, there are visual problems. There are change in the reflexes and irritability, all that due to microedema in all tissue due to the vascular dysfunction. Now, with regard to the management of the preeclampsia, of course, we have to look at majority of the patient will be managed in the clinic, but you have to offer admission if you are dealing with a high blood pressure or any deranged maternal biochemical or hematological investigation. And of course, remember that we are actually relying very heavily on amount of protein and creatinine protein ratio, and of course the liver enzyme and platelet counts, and of course irritability and other symptoms which might probably put you into what we call impending eclamptic fit or eclampsia in a patient who was actually diagnosed with preeclampsia. And I mentioned about the edema before, rapid development of edema, and of course the hematological evaluation. I'm not going to dwell on it a lot, and of course you look at the platelet count and reduction in the platelet count, indicating microangiopathy, and but you have to make sure that you are not talking about immune or non-immune thrombocytopenic purpura. ITP is very common in England, and therefore we have to be very careful with low platelets. When there's a low platelet, we have to make sure that we are not dealing with ITP. And of course, with regard to the other parameter, we are looking at like prothrombin time, INR, APTT. All the investigation should be done in addition to the liver function, urea electrolytes. And of course, with regard to the microangiopathy, it might lead to iron deficiency anemia, and this is actually part of a picture of preeclampsia. Ophthalmological findings, and due to retinal vasospasm, we actually offer sometimes patients with blurred vision to do fundoscopy in order to rule out any hemorrhage in the retina. And these condition might actually simulate like retinal detachment, which normally reversible after delivery of the baby. In the clinic, of course, we rely heavily on the measurement of the protein in the urine, and in any clinic in the UK, there's a machine measuring that for us, and the cutoff for measurement 30 milligram per at a threshold for abnormality. Above that is abnormal, below that is normal. That's according to the NICE guideline. Kidney dysfunction, of course, we used to do, I mean, normally you should have no protein or less than 1 protein. Maybe 1 plus proteinuria acceptable due to the increase in the vaginal discharge, but the level 2 blood or greater is an indication of 24-hour urine collection, although we don't actually do it now because of the protein creatinine ratio. Protein creatinine ratio is very, very accurate, and therefore we rely on it very heavily in the UK. I mentioned about the hepatic involvement and lung involvement, also due to the vascular dysfunction. And of course, there's indication that echocardiography and electrocardiography might be actually indicated to rule out or evaluate left ventricular heart in chronic hypertension, and to exclude cardiomyopathy or occult valvular disease in patients with hypertension or chronic hypertension, and in patients with very severe PET. Brain, of course, the picture of the brain, as you can see that the picture is due to the microedema, which lead to the change in the reflexes and irritability and visual disturbance. And MRI, occasionally we do MRI, especially if the patient complaining of chronic headache, but not routinely. Now, fetal monitoring in chronic hypertension, according to the new NICE guideline, in women with chronic hypertension, carry out an ultrasound for fetal growth and amniotic fluid volume and umbilical artery Doppler velocity. That's a routine in patients with preeclampsia at 28 weeks and 32 every 4 weeks. And in women with chronic hypertension, we do only the cardiotachography. We don't do it routinely in chronic hypertension, but we do it routinely in severe PET. Fetal monitoring in gestational hypertension. Remember that what we say that gestational hypertension developed during the latter half of the pregnancy in women with gestational hypertension, and ultrasound for fetal growth and amniotic fluid volume and artery Doppler is mandatory now, and it has to be carried out every 4 weeks. In women with gestational hypertension, only carrying out cardiotocography if it's again clinically indicated. I think I try to stick to the NICE guideline to remind you that there are a lot of change in the guideline, and I thought that I will need to highlight it to you in order to be familiar with that and probably change your practice. And the NICE guideline is available in the internet. Fetal monitoring, of course, is very important in preeclampsia, and like I mentioned before. And I mentioned something about the gestational hypertension already, and more something about gestational hypertension, which I actually mentioned already again. The effect of the hypertension and in relation to the obesity, again, I mentioned before earlier on. And the the thing about the new development with regard to the prediction of the screening of the patient for preeclampsia, it is actually available, but not widely available, because it is, although recommended by the NICE guideline, but it is not mandatory until now. I think probably we are there, and I think if we go to the timing of the birth in women with preeclampsia, of course, this is depending on the degree of the fetal syndrome and degree of the maternal syndrome. And of course, with regard to the chronic hypertension, we say that there is no longer indication to deliver the baby around 38 or 39 weeks. If the blood pressure well controlled, you continue until full term. With regard to the preeclampsia, all depending on the severity of and the control of the hypertension in preeclampsia, and therefore it is variable. But we recommend that with regard to preeclampsia before 34 weeks, I think you have to be vigilant about the prematurity, and therefore you have to make sure that you try to avoid it. But if you have to do it, especially before 32 weeks, don't forget that intravenous magnesium, which I mentioned last night, for neuroprotection is very important in addition to corticosteroid. Thank you very much.
Thank you very much, Mr. Halu, for the nice presentation. And the second speaker is Professor Ali Naqash from Croydon University Hospital in London, and he is an honorary senior lecturer at Basra Medical College. He is going to cover the second part of hypertensive disorder during pregnancy, and he is going to talk about treatment. Yes, please.
Ali, tell me if you can see the screen. Can you see it?
No, we can hear you, but yeah.
Can you see the screen?
Yeah, this is clear.
Okay, let me just start from the beginning. So that's the presentation, all of it. Okay, so we start with the end. This is the last slide. So I thought, yeah, laughing can help, I tell you. At least in my case, it works. So nice to see you again here, all of you. And this is going to be centered around treatment, but as well, I'm going to touch base on the principles. Rahim, he talked about the classifications and how many types of hypertension, and the preeclampsia is only one part of it, and also about the recent criteria of diagnosis of blood pressure, which is, I find somehow confusing, because according to the latest NICE guidelines, that we should take a cutoff figure, which is 140/90, and 140/90 in their regard is abnormal. They should be treated 140/90 and over. And does this go with the clinical practice? I doubt it. But anyway, that's the NICE guidelines. And regarding the proteinuria, obviously the definition is known to everybody. The quantitative definition, the day-to-day practicality, if you have 1+ is okay. When you do the dipstick in the urine, if more than that, it means you have proteinuria. And this is very important, because if you have a proteinuria, then you are dealing now with the toxemia of a pregnancy or preeclampsia. Then the term gestational hypertension, which is really the innocent part of it, because if it stays gestational, that's fine. because most of the time the morbidity is not as high, though there is still a reported increased complication like abruption, preterm delivery, and small for gestational age. But as long as there is no superimposed preeclampsia, you should be all right with these patients, but you have to keep checking her urine every time she comes to the clinic. In the UK, the most important thing is the booking blood pressure, because there's so many women, they come with a booking blood pressure of like 130/80, while others, their booking blood pressure is 90/60. I remember my wife, her booking blood pressure was 90/60. So when her blood pressure later on gone up to 120/80, ooh, we thought that's quite a jump. So the risk factors, we all know about it. I just want to highlight two things. Smoking, funny enough, is protective against preeclampsia. They noted the lady who smoke, they have 30% less incidence of a preeclampsia. I'm not promoting smoking here, but this is one of the funny things about science. Regarding alcohol, if you're drinking alcohol, obviously our women don't drink alcohol, but here they do. And I meet so many pregnant ladies who have a social drinking, and usually it's fine. And they say it's only if you have a binge drinking. What does it mean, binge drinking? You have a weekend in which you suddenly, instead of having 10 units of alcohol, you have in this weekend alone like 40 units of alcohol because you carry on drinking and drinking. And that's what can harm the pregnancy. But otherwise, most ladies here are very sensible, because when it comes to alcohol, they either drink or they don't drink at all. They drink socially. You're allowed up to like 15 units a week. So the physiology of blood pressure, you all know about it. I just want to touch base on that. We have three common organs which deal with the problem. It's the kidney, it's the heart, it's the brain, and the adrenal cortex. And the way it works, I think the kidney here is the main player. And if there is any disturbance when it comes to the kidney, everything go down the hill. And don't forget the physiological changes of a pregnancy, because normally the woman would have increase in her cardiac output, normally 30%. And normally there is increase in the blood volume. So these on their own, they would make the blood pressure jump up. And then there was also physiological reduction in the mid-trimester, which can confuse things. So in real life, when this is the commonest problem you find in real life, lady coming in to checking her blood pressure, and then suddenly you have this lady having a blood pressure on 140/90. And then when you look at her booking the blood pressure, it was kind of 100/70 or something. And she's having mild symptoms. So what do you do with these ladies? This is the commonest kind of presentation. If you're going to admit or treat everybody like these patients, then you're not going to have enough beds for anybody. And therefore, they have a clever system here in which they utilize the beds skillfully. We have, like in our unit, maybe 20 antenatal beds. But the number of ladies who come in with high blood pressure each day alone is over 30 patients. So what they do, they come to a unit called day assessment unit, like a triaging unit run by the midwife. They check their blood pressure, they do their bloods, and if the blood pressure comes very high, like 150/100, they don't panic and they just admit her. No, they keep her sitting aside. You remember when Rahim was talking about when you take a blood pressure, it's not what you take one-off reading and say, bye, you have blood pressure. No, you can repeat the blood pressure after she rests and relax after 10 minutes, 15 minutes. And sometimes you keep them up to 2 hours, doing it every half an hour. And most of them, the blood pressure will settle eventually. And the patients here are clever as well, because so many of them, they have these automated machine they can buy from the pharmacy, and they learn how to use it. And many of them, they come and she has a small book in which she can show you, doctor, this is my blood pressure. I've been following it over the last 2 weeks. And then you look at it and you see the fluctuation. And then you think, oh, this patient, I trust her. I trust her judgment. I can send her home even if I want to start her medication. And then there is the very bad cases, like what Rahim said, the African ladies, the black ladies. These are the very unpredictable ones. These are the ones who can jump up from mild hypertension into fulminating preeclampsia within a matter of a day or two. And these are the ones we should be careful about, because our population is quite diverse. You are lucky in Basra, you have one sort of patient. In our unit, we have 10 types of patients from everywhere, and they all behave differently. So essentially, what are the rules? When do you admit? When do you not? Yeah, NICE guideline can give you these set of kind of tables, nice tables. You start off your medication there, you admit there, but real life is very different. Real life is very different. There are ladies who come in with a blood pressure of 165 over 120, and everybody gets panicky. And then within an hour, it comes down to 130 over 70 without doing anything. So essentially, very important is not to panic. It's not only the blood pressure. You have to check the urine first, just to make sure, is she preeclamptic or is she simply gestational hypertension? And then send the blood test for her. And the blood test is important. When they come back, you look at the enzyme, liver enzyme, look at her GFR, look at her creatinine, and then your clinical assessment. There are so many patients, they come in with a moderate hypertension, like a mild degree. And then when you examine her, you see she looks ill. She's hyperreflexic. She feels nauseated and sick sometimes. It's very common in preeclampsia. They have the sickness, sudden attack of sickness, epigastric tenderness. This is your judgment as a clinician, because if without this judgment, you are not a clinician. You are simply probably a midwife or a porter who just read the guidelines and the protocol, and he thinks he can manage patient. So chronic hypertension in a pregnancy, we face that a lot these days because there are so many of these elderly ladies who got pregnant. They are over 40. So what do we do with them? Obviously, you check her the way you check everybody, and then you have your medication available in front of you. The commonest tablet we use here in the UK is not methyldopa, is not nifedipine, is labetalol. Labetalol is the magic medicine. We always start with it, almost always. And usually when you start with the labetalol, you start with the least effective dose, like 100 milligram twice a day, and see how it works. And then you can increase it to 200 twice a day. If it doesn't work, you can increase it to 4 times a day. Your maximum allowed dose is 2,400 milligram. So there is a huge way of maneuver. So you don't need to panic if she hasn't responded to labetalol 200 twice a day, and then you just shift her or add nifedipine to it, because I found nifedipine can complicate the picture. Nifedipine is very good because it is immediately bring your blood pressure down within kind of 10 minutes, but it can cause severe headache. And then you don't know this headache, is it because of her blood pressure or because of her nifedipine you just given to her? Because when she came in, she was perfect. She didn't have any headache. I've seen so many cases like that. And some of them, they end up in unnecessary delivery just simply because of the severe headache. You know, severe headache means sometimes, oh, she's severe preeclampsia, I need to start magnesium on her. And imagine, once you go down this route of magnesium, then this lady going to need a cesarean section or induction very soon, because you committed to yourself. So be careful. The important things, experience is very important. Your clinical sense is very important. Everybody knows sick patient when they see them, because sick patients shout at you. They don't look well, even if their blood pressure is normal. They don't look well, and you identify them cleverly because you've seen it before. You've been there before. So these sick patients, you're going to recognize what you're going to do with them. You're just not going to keep on repeating their blood pressure. You're going to admit them regardless. And then you're going to think about a plan what to do with them. And then some people, old-fashioned people, like methyldopa. Methyldopa is not a first line, it's a third line right now. And for some reason, some GPs here, they like using it. And it takes ages to work. and is known to cause depression in women. And sometimes, if she is a postnatal, it can put off the baby of milk. Baby cannot take the milk because they think it can make the milk bitter. So I don't like methyl dopa unless I foster it, because this lady already on it and she is happy with it. So as we said, acute severe hypertension is the problem. It's a medical emergency and it's a quite common one. And you need to act quickly, because here you are worried about one thing only, and that is she going to fit in front of you? Because in UK, if a lady fits, that's a major incident. This you're going to need to justify why you allowed her to fit, why you didn't treat her before she got to that. And probably in Basra or in Iraq, the atmosphere is more relaxed about that, because that's fine. We've seen it before. She's done it before. But in developed world, oh, that's a tragedy. When you come in the morning and you know there was an eclamptic fit, the gossip is all around. Why it happened? Who happened with? Who was treating her? And then you be in the front line. If you're a consultant, obviously you have to be in the front line. You cannot hide about anybody. You cannot say it's because of my registrar and all that. It's your responsibility. So you have to make sure it doesn't happen. So what is your weaponry? What is your weaponry to deal with severe hypertension? It's essentially the same stuff, but there is one very important thing. Before that, I come to the idea of bed rest and hospitalization. So many people in the past, they used to, she got blood pressure, keep fluctuating, let's just admit her in hospital and watch her, and she almost likely she would be better. That doesn't work any time, because the things have changed. There is not enough beds. We cannot just admit patient nowadays for bed rest, because that there is no bed. We cannot afford that. When I was an SHO in UK, we were doing it. Now it's different. It's all changing. So regarding the antihypertensive, I talked about it a little bit. So these are the labetalol is the commonest medicine we use. I don't know, is it the commonest in Iraq or in Basra? I'm not sure about it. So what it is, labetalol is a joint beta and alpha blocker, and it works. And we know it works. The only thing about it, some report, it says it might cause hypoglycemia for the unit afterwards. But so what? Yeah, you're not going to have a hypoglycemia intrauterine. You're not going to worry about that really. You're going to treat the patient postnatally. I've seen patients on labetalol up to 3 weeks and they're doing fine. And because that's the other issue, what do you do after birth? When do you switch medication? Because what's used by obstetrician is not what is used by physician regarding hypertension. Methyldopain is an old style medication, been there for ages and loved by many people. However, is coming out of fashion, but it's still prescribed here. And I mentioned about the depression, it can cause fatigue, but if it works for some ladies, so what? So the other decision, you as a doctor, when do we deliver these ladies? When do we induce them? We all know if you panic, you're going to section everybody. And you shouldn't do that, because you are a doctor, you're a clinician, you're not a midwife. The midwife would like to get everybody delivered as soon as possible. And once you have a patient with high blood pressure, she's going to put a lot of pressure on you to interfere really and intervene. However, the last guidelines come to support the doctors really, and saying that ladies with chronic hypertension, with the blood pressure lower than 160 over 110, don't panic. You don't need to induce them. You can watch them until they are more mature, 39 weeks. And we all know when you offer inductions with ladies with a preeclampsia or hypertension, for some reason the induction would work. Most of the time, these prostaglandin work in these patients. And I rarely seen induction with a prostaglandin fails on a lady with a preeclampsia. In fact, their labor happens so quick. Then if you decide to deliver early because of her very fluctuating high blood pressure, and for some reason you decided, for example, to even offer her cesarean section, then don't forget about the steroids, because you don't want to bring the baby just to deliver the baby and hand over the problem to the pediatrician, because that's not the way it works. Because you might save the mom. What about the baby who's going to need a SCABU or NICU for 3-4 weeks, especially in Iraq and Basra, when we know that a mom might deliver a healthy baby, the baby might die 10 days later because of inadequate care in the pediatric unit. So acute severe hypertension is obstetric emergency. You should use whatever you have. Your first line is labetalol, again, not oral, I would say intravenous drip, because now you need to deal with the problem. You need something to act quick. Some people just give 10 milligram of nifedipine and hope for the best. Most of the time it works, but it rebounds after 1 hour and the blood pressure comes back again. Only this time the lady having severe headache because of the nifedipine. So it kind of complicates the picture. Some people like giving nifedipine straight away. I think if you are there, stick with the labetalol. And in the old days, we used to give hydralazine, and then you have to titrate it over 10 minutes slowly, because you give it 10 milligram intravenous. Is not as often as before. Is mainly because of this. You have to give it slowly, and you have to sit with the patient, and you can do it 2 to 3 times until you get the blood pressure under control. And because of the hectic nature of most labor ward, they cannot afford to let the registrar just sitting with one patient for the next half an hour, just giving her the medicine, looking at the blood pressure, because it doesn't work like that. He would be needed for many more patients, probably as urgent as that one. So better to start IV infusion of labetalol and watch the blood pressure come down gradually. And then don't forget about the magical medicine, which is magnesium sulfate. So medication safety. What is medication safety? We're using them every day, so they must be safe. The one we're not using are the ones which are not safe, which is diuretics. We don't use them in the pregnancy because we're going to play with the volume. And the preeclampsia, don't forget, is a volume problem, is a kind of vasculitis. When we have a severe preeclampsia, it's not an obstetric issue alone, it's an anesthetist issue. Whenever we see a lady with severe preeclampsia, we don't go alone, the obstetrician just go to that room. We always drag the anesthetist with us, because one important part of the management of severe preeclampsia is the fluid management. I'm pretty sure anesthetists are very vital in this situation, and you should utilize them. And if they try to drag themselves away, pull them in, because they are doctors. They are not technicians as we might think they are. They are doctors, and they are very clever when it comes to these things, the fluid management. ACE inhibitors, we should not use them because they are teratogenic in the pregnancy. And you know what I mean by ACE inhibitors. I am on one of them, lisinopril. There is the capotina, the one famous in Iraq, captopril and enalapril, lisinopril, all the pril family, and they shouldn't be used in pregnancy. We can use them though postnatally after delivery. Why we cannot use them? They can cause fetal renal agenesis. They can, in the baby, obviously, cardiovascular abnormality, neurovascular abnormality. So you should stay away from them. Stay away from diuretics. So anticonvulsants. Here's a nice story to tell you about the anticonvulsants. When I came first to UK, started working in like 98 or something, we used to rely on mainly one medicine, which is IV diazepam, Valium, to control these fitting ladies. And everybody knew there is some magical medicine used everywhere else in the world, including America for the last 20, 30 years, called magnesium sulfate. But UK don't want to use it because at that time there was no trial, no randomized controlled trial, which proved the safety of this medicine. Even everybody saying at that time, it works, it works. So when it comes to evidence, your observation, my observation, 100 doctors' observation, means nothing, is only a weak evidence. What is stronger evidence, though, is a randomized control trial. So there was no randomized control trial at that time, and then things changed. It was a randomized control trial, and they proved that this medicine, the unvalued medicine, it does work. Not only that, you should give it to eclamptic lady because it reduced the incidence of recurrence of fits. You should give it to any lady with severe preeclampsia. See, when you come to lady with severe preeclampsia, any lady can be with severe preeclampsia when you decide she is. Because if a lady comes to you with severe headache, she can be severe preeclampsia. She can be fitting for magnesium sulfate. So be careful here. Here comes the role of a doctor to use his judgment when to start the magnesium sulfate. Because whenever you start a magnesium sulfate, you are kind of committed yourself for delivery. So you should be very careful. And whenever you use magnesium sulfate, you should bring the anesthetic immediately with you because there is going to be a fluid management as well. And the fluid management, the best one who can do it is your colleague, the anesthetist. So talk to them, involve them, let them share you the responsibility. Don't let it all on your shoulder. So how do we give it here in UK? Everywhere in the world, they give it intramuscular injection, but they say it can be very painful. I don't know about that. You should ask the woman who had intramuscular magnesium. Here in the UK, they give the bolus dose 4 grams over 30 minutes, IV, the bolus dose, and then after that, maintenance dose, and that's in a drip over the next 24 hours. And that time, you're going to buy time to control the lady, make sure her bloods are fine, she's not going into HELLP syndrome, her platelet is fine, and her blood pressure is controlled, and then you have to make a judgment how you're going to deliver her, that's the most important, because what we know the only cure for preeclampsia is when you get the placenta out. So when do you think this lady needs magnesium sulfate even though she is not fitting? Because fitting is too late. You're going to be criticized. Why should you get to that stage before you use magnesium? So you see how this is how things change now. Now they are in love with magnesium sulfate. Magnesium sulfate is in any emergency trolley. The first thing you find is the magnesium sulfate. So look at the criteria for severe preeclampsia. And any one of these is enough indication. Severe headache, visual scotoma, nausea, vomiting, severe epigastric pain, oliguria, severe hypertension. By severe hypertension, according to the latest in NICE, is when the blood pressure is over 160, over 110. So, and then you can use the blood as well, progressive deterioration in laboratory blood tests. But you are, as a clinician, I would say you depend on your clinical judgment. Whatever, even if the blood tests come back as normal, you should look at the patient and decide, is she a sick patient or is she not? Is she the one who's going to fit after half an hour from there? Yeah, you don't have this crystal ball, but you have your experience. You have the cases you missed before and you learn from them and you don't want to repeat your same mistake again. So this all come into your decision at that critical moment. It's you and you alone, and don't let anybody influence you. So as I said before, a lady who goes into severe preeclampsia is not only a problem, it's the anesthetist problem. He should come in, he should make sure that she has a fluid restriction. You might say, oh, fluid is important for blood pressure and all that. I'm giving her all these antihypertensive. No, it's not, doesn't work like that. You should, the anesthetist, they call it make her dry. Make the patient dry. How do you make her dry? When you reduce her fluid input to 80 ml an hour, and they be happy, they be only then happy, and then you keep monitoring on her urine output. Because why do you do that? Why do you do? You might say, why do I make her dry? PET, preeclampsia, is a vasculitis problem, is a fluid issue. The fluid you pump in, where does it go? It go into the interstitial tissue. It's not going to stay in. You're only going to cause a more cerebral edema, and she might go into confusion and die on your hand. So postnatally, now you deliver that lady, and she is fine, and you come in to see her. Her blood pressure is still high. What are you going to do for that? What's your follow-up? Very important, a plan for follow-up, because your job is not over yet. You might send her home today, and she come after a week with a stroke. I've seen a patient like that. That lady died on that morning. It was my first week in that hospital. She delivered just 2 weeks ago, moderate preeclampsia, and she young mother, and I was on call on that day. They called me to the A&E because this lady came in unconscious with a constricted pupil, and when we looked, she was discharged just 7 days ago. So it happens even in the UK. It can happen anytime and anywhere. So how do you protect yourself against that? Is by making a good watertight postnatal follow-up for her. Well, you cannot keep on seeing her every day and check her blood pressure, but you can have a plan for her. Tell her on the second day there is somebody to come in.
Excuse me.
Do you hear me, Ali? Any problem?
Hello.
Okay.
You have an interruption a little bit. Could you please repeat it a little quickly?
Okay.
Repeat the postnatal investigation and monitoring.
Postnatal investigations and monitoring. Do you hear me? I would say
yes,
for the first 2 days after birth, and then on day 3 and day 5. And then obviously here they have a midwife who can check the blood pressure at home. And I don't think you have that in Iraq, but you have to find an arrangement for her to get reviewed postnatally in the community, just to make sure your medication you're given to her is not kind of needing come upgrading, increase the dosage or adjusting. So what do you offer her postnatally? What kind of medication? Now you still obstetrically, she is obstetric lady because she is within 6 weeks. She's still in the puerperium. But what most people say, patients can keep on taking labetalol up to 3 weeks after, not after, beyond that. And then you can get her back to medication like enalapril, ACE inhibitors. And for Black ladies, consider nifedipine or amlodipine, if the woman been previously on that. But be careful about one thing. Make sure she's not about breastfeeding, because there is some issue about giving ACE inhibitors in a breastfeeding woman. So if she is a breastfeeding, what do? You shouldn't, they advise again giving ACE inhibitors. And if her blood pressure is still up, sometimes one medication is not good enough. You have to use nifedipine or combination of nifedipine and ACE inhibitors. So you have, and then if it's still this not working, you have to join effort with your colleagues. You shouldn't just take it on your own. You should ask the physician just to have a look as well and see if they use one of their clever ideas. So the methyl dopa, we talked about it. It's an old-fashioned medication. It's been there for ages. And the fact it's been there for a very long time, it must prove one thing, and that is safe. It is safe. So it's still safe to be used. It's still safe to be used even postnatally. And I've seen ladies who use it outside the pregnancy. So this is one of your options. And you can always liaise with your GP. And there is some clinic for particularly for hypertension, and that's for the medical people who can see her later there. Because what is for you is important. Is it a case of essential hypertension, which is going to be there with this lady for life? Because if it is preeclampsia, it should go soon after delivery. If it is essential hypertension, it will stay with her for life. She might need to be investigated further. And for you, your duty is not to miss these essential hypertension. So coming back to the ACE inhibitors, the capotine, I think capotine is still widely used in Iraq, and lisinopril, alinopril, and all that. They are good medications, and but people on it, they always need to be checked for kidney function, and also make sure that she's not breastfeeding, because there are reports that they can go in the milk and can bring down the blood pressure of the baby. So we usually don't use diuretics immediately, and diuretics even is not a first-line antihypertensive nowadays. But sometimes you need to use it even in the postnatal period, because, for example, if the blood pressure is not controlled. But be careful, if she is breastfeeding, this is going to stop her milk coming, because you drying her out, and these diuretics, you shouldn't give it in a lady who's breastfeeding. In the community, what women does, they can check their blood pressure themselves. This machine available everywhere. So many people try to discredit them and tell that it doesn't give you the whole idea. But believe me, I have one of these at home. When I go to your GP, he used one just like mine. So I say, if my GP used the same blood pressure machine I use, so they must be kind of good, because otherwise the GP can use the old-fashioned fig and all that, but no one uses it nowadays. They all use the same automated one. But make sure you don't buy anything which is kind of unknown brand. Make sure you buy something with known brands. And then what you do in order to double check, you check your blood pressure, check your blood pressure to the other family members who don't have blood pressure, and just to double check on the readings and make sure this readings is the right readings, because that's what I do. If I'm not kind of sure about my reading for blood pressure, I go and ask my wife to check her blood pressure, and I might ask somebody else to do it, just to do my own checking on my machine. So it does work. Laughing lower, I believe in that. Thank you very much.
Thank you very much, Mr. Ali, for your nice presentation, really. And the third speaker is going to be Ali Mohsen. He is a medical manager of Hasino Company, and he is a lecturer at Al Mustansiriya Medical College. His lecture is going to be about UTI and pregnancy. Yes, please, Dr. Ali. Yes, Dr. Ali,
okay.
Can you start,
Can you
please?
hear me now? Can you hear me?
Yeah.
Okay, thank you very much, Dr. Ali, for your nice presentation. And my presentation today will be about guidelines of UTI in a pregnancy, in which I will talk about asymptomatic bacteriuria in pregnancy, of course. Sorry. Non-complicated cystitis in a pregnancy, and my main reference in those two topics will be the most recent version of NICE guidance about urinary tract infection, antimicrobial prescribing. Also, at the end of the presentation, I'll talk a few words about nitrofurantoin and its features. So, asymptomatic bacteriuria in pregnancy. According to the NICE guidelines, when managing symptomatic bacteriuria, a clinician should be aware of the following. Symptomatic bacteriuria represents significant levels of bacteria that may be greater than 100,000 colony-forming units per mole in urine without symptoms of UTI. Also, routinely, symptomatic bacteriuria is not screened for or treated in women who are not pregnant, or in men, or in young people and children. However, in pregnancy, symptomatic bacteriuria is routinely screened for and treated with antibiotics because it represents a risk factor for pyelonephritis and premature delivery. So to have an idea about those potential risks of asymptomatic bacteriuria in pregnancy, clinical trials have shown that up to 40% of asymptomatic bacteriuria cases among pregnant ladies may progress to pyelonephritis. This is in case of no screening and management or treatment of asymptomatic bacteriuria. Also, without treatment of asymptomatic bacteriuria in pregnancy, 20 to 50% higher incidence was noticed of preterm birth and low birth weight in those cases without treatment. On the other hand, with appropriate screening and treatment, less than 1% of bacteriuria cases will progress to pyelonephritis. Okay, what about uncomplicated cystitis in pregnancy again. According to the same guidelines, in cases of uncomplicated cystitis, the guideline recommends to offer an immediate antibiotic prescription to pregnant women with lower urinary tract infection, keeping in mind the following. Number one, the previous urine culture and susceptibility results, if present, of course, and previous antibiotic use. And this is very common in Iraq. The patient comes to the gynecologist with UTI and with a previous use of antibiotics prescribed by other doctor or maybe by a friend or by herself, etc., which may have led to resistant bacteria. So ideally, midstream urine sample should be obtained before antibiotics are taken and sent for culture and susceptibility testing. Then, after the result, a review of the choice of antibiotic may be made and the change of the antibiotic according to the susceptibility results, especially if the bacteria are resistant, using preferably a narrow spectrum antibiotic wherever this is possible. Now, the NICE guidelines have summarized the antibiotic options for urinary tract infection in a pregnant woman aged 12 years and over in this table. Dr. Ali, you can see my presentation synchronized with my speech, or there is a delay?
Yes, it is clear. You can go.
Okay, thank you. So do you have, you are seeing the table, right?
Yeah.
Okay, thank you. So, according to the NICE guideline, the antibiotics were classified into first choice and second choice options. For the first choice, for treating lower urinary tract infection in a pregnant lady, the first choice, of course, here is nitrofurantoin. The dose is 100 milligram of modified release nitrofurantoin given twice a day. However, if modified release formulation is unavailable, it is fine to give 50 milligram of nitrofurantoin immediate release, but here it should be given 1/4, and in both cases, the duration of treatment is 7 days. It is important to mention regarding nitrofurantoin that it should be avoided near the term, and it must be given, or it should be given only if the patient has a good renal function. In other words, glomerular filtration rate more than 45 ml per minute. The second choice options, which are be given when there is no improvement during the first 48 hours after starting the antibiotic, or when the first choice is not suitable. Here, amoxicillin, cephalexin, and other antibiotics that are safe in a pregnancy are recommended. However, we should keep in mind that amoxicillin should only be used if culture results are available and the bacteria is susceptible. This is because E. coli, which is of course the most common pathogen in urinary tract infection, showed a relatively high resistance to amoxicillin that might exceed 20% and may reach 25–27% of strains of E. coli may be resistant to amoxicillin. Coming to treatment of asymptomatic bacteriuria, which, as the guideline mentioned, must be screened for and treated in a pregnancy if the antibiotic options include nitrofurantoin, amoxicillin, or cephalexin based on recent culture and susceptibility results. If we look at other guidelines, other than the NICE guidelines, here, for example, the table for antibiotic options for the treatment of lower urinary tract infection or uncomplicated cystitis in general, as European guideline doesn't have the separated table for pregnancy and non-pregnant lady. But in general, they recommend also nitrofurantoin, modified release 100 milligram twice daily, and in addition, of course, to other options like fosfomycin. Regarding trimethoprim and other antibiotics, there are some cautions when they are used in a pregnancy because according to the data, trimethoprim should not be given in the first trimester, and the combination trimethoprim sulfamethoxazole not should be given in the last trimester of pregnancy. However, we have seen that the guidelines repeatedly concentrate on nitrofurantoin as the first option antibiotic or one of the first options antibiotic. So why is this? Especially if we put in mind the fact that nitrofurantoin actually is a very old antibiotics that has been present in the practice since the 50s. Nitrofurantoin has a unique mode of action. According to its complicated way that of eradication bacteria, nitrofurantoin was found to eradicate or kill bacteria in 5 different mechanisms. The most important one, of course, is the complete inhibition of a protein synthesis. In addition, it inhibits carbohydrate metabolism. It inhibits also cell wall synthesis, inhibition of DNA synthesis, and finally, inhibition of RNA polymerization. That's why it's very difficult for any bacteria to develop resistance against nitrofurantoin, and this is clearly reflected on the clinical practice when we look at the figures of resistant E. coli nitrofurantoin. We find that it doesn't exceed 3 to 5% of E. coli strains being resistant to nitrofurantoin. One more thing to be mentioned regarding nitrofurantoin. Actually, nitrofurantoin is made either by the traditional way, which is a powder of nitrofurantoin, or immediate release form. When you open the capsule, you find just a powder of nitrofurantoin. And here, this formulation is rapidly absorbed from the GIT. The more recent formulation is the retard nitrofurantoin that is formed as large pellets filling the capsule. So what is the difference? If we look at the absorption, of course, the powder, due to the larger number and smaller size of the particles, it is rapidly absorbed from the gastrointestinal tract. Here, on the other hand, the retard formulation is slowly absorbed, and the result is the following. The powder formulation is characterized by higher incidence of gastrointestinal disturbances. In addition, it needs to be given more frequently, 1/3 or more ideally 1/4 dosing interval. On the other hand, the retard formulation or the macrocrystalline formulation should be given only 1/2, and by this way, by using retard formulation, we have reduced gastrointestinal side effects, and we have improved the patient compliance, as it is much easier to have an antibiotic twice daily rather than 4 times per day. This is my last slide, and I thank you very much for your listening, and back to you, Dr. Ali.
Thank you very much, Dr. Ali. Now we have 15 minutes for question and answer, and we start with Mr. Haloub. Mr. Haloub, are you ready?
I am okay, yeah, thank you.
The first question is there any rule of metformin as a protective measure for preeclampsia?
No, metformin, we don't actually give it for preeclampsia, and there's no indication to give it. Metformin, we give it widely in infertility patients. Patients with infertility, normally coming with pregnancy, we continue until full term. And we did not actually notice that a patient with on the metformin had low chance of developing hypertension or preeclampsia. Or from my observation, patient on metformin, whether diabetic patient or non-diabetic patient, they actually do develop preeclampsia.
Okay. The second question is, which arm better to be used to measure the blood pressure? Is it the right
Both
or
of them.
left?
No, both of them. Any arm can be done, but if you think or if you feel that the blood pressure can maybe not actually recorded very well, then, or maybe high, then you can try another arm. Both of them is okay. But it has to be at the level of the heart, and that is the main issue. The machine should be at the level of the heart, and the cuff at the level of the heart, yeah.
Another question is, why the interval less than 2 years or longer than 10 years is a risk factor?
That observation, Ali, I can't actually comment on that. Observation that if the pregnancy be before two years or longer than 10 years, maybe immunological factor, maybe other factor. You remember that probably we learn a lot from the hydrogen mole, and sometimes you might actually have a trophoblast from a pregnancy about 4 years ago. So it's immunological.
What about the prognosis of hydrocephalus and preeclampsia?
In what way? The prognosis, in what way? Meaning that because the problem with the hydrocephalus is the measurement you actually do, and what do you do when you have hydrocephalus? And the delivery is very important. The timing of delivery is very important. Of course, you don't actually leave hydrocephalus until major degree, because you will have a heart failure, you have a deterioration of the vasculature everywhere, and therefore maturity and development of hydrocephalus is very important to look at, and therefore you have to weigh prematurity with the delivery.
Another question for Dr. Ali, I think. Define the amount of units of alcohol used as prophylactic against preeclampsia.
Alcohol for
What is how much alcohol is protective against preeclampsia?
يعني this is the last question I was expecting.
Can I actually from the fertility point of view?
Rahim, this is my question. Let me answer.
Okay, fine. Right. Okay. I thought you are not going to answer
Well,
it.
I have a special interest in alcohol.
Okay.
By definition, you're allowed up to 15 units a week of alcohol. Yeah, حتى يصير social drinkers. More than that is abnormal. يعني, but believe me, the ladies here are very sensible. يعني more, I rarely find somebody who go and binge drinking. Binge drinking هو المشكلة. شنو يعني؟ يجيب لك انت كرتونة مال بيرة وتريد تشربها بليلة. هاي يسموه binge drinking. يعني تشرب لك فد 100 unit بظرف 24 hours. How it can harm the pregnancy, and I never seen a lady who done that. Tell you the truth.
By the patient is dead anyway.
هنا طبعا العشيرة تقتلها قبل ما حد يقتلها.
I think we go by the Royal College recommendation, and we go by from the fertility point of view. With regard to the infertile patient before getting pregnant, we advise the following: the patient, the woman should not drink alcohol, occasionally only, and I tell them once in a blue moon. What's the meaning of once in a blue moon? Once in a blue moon meaning that you look at the window, and if there's a blue moon, you take one unit. That means probably never. With regard to the man, the maximum 8 units. But when she is pregnant, that advice will continue. The woman should be advised not to actually drink alcohol at all, or occasionally. 15 unit alcohol, 15 unit Ali, 15 unit is actually a lot of alcohol.
يعني high based on experience?
One. Well, neither pregnant nor infertile.
Based on experience, yeah.
But that is the recommendation, basically. Recommendation from the European ASHRI and recommendation by the Royal College.
reality, women, they still, when they get pregnant, I've seen them, they drink in the weekends. They drink a pint or two. Pint اللي هو how many units?
Pint 2 units. Pint of alcohol beer is 2 units, and therefore we tell the patient that you are allowed occasionally to drink half a unit, half a pint. 1 year.
بس ما nobody
But
do that.
not- but not regularly.
Nobody
But not
sell you
regularly.
have a pint. هو الباينت سعره 1 pound. ما حيبني لك نص الجلاس.
No, there is a half a pint for lady.
انت ظاهر knowledgeable about that.
Well, to be in the UK, you have to be knowledgeable because this is a social interaction.
طبعا.
Another question
But
is labetalol available in Iraq? I think only tablets are available.
ها عندكم
And it
labetalol.
is
عندكم labetalol.
private, but it is not available in the general hospital. I didn't see it really.
So what is your first line antihypertensive?
Still, we are using methaldopa.
Really? ليش؟
Methaldopa and apresoline, they are both available.
ليش methyl dopa علي؟ يعني it's not like labetalol is more expensive. ما أعتقد labetalol is more expensive.
Yeah, but it is not available.
Nifedipine?
Yeah.
Well,
Nifedipine.
احنا كان عندنا عدلات. أنا أتذكر كان عندنا عدلات اللي هو
That's not-
calcium channel blocker.
yeah, that's nifedipine. Adalat, yeah.
Still Adalat available. Still Adalat.
موجود
Yeah.
عدلات.
Yeah.
What are the advantages of labetalol over methaldopa?
Yes, methyl dopa is very slow to work. يعني شنو معناته؟ يعني أنت lady coming to you with symptoms with high blood pressure. If you're going to give her methyl dopa, that's mean you're going to admit her because her blood pressure is not going to settle in front of you. She's going to stay in. The people say methyl dopa need 48 hours to start working. Some people say, yeah, this is the slow action. As a safe medicine, it is a safe medicine. However, it's not free of risk. There's many women who get depression on it. And for the baby wise, it's very safe. But I personally don't understand why labetalol doesn't come into the Iraqi market because this is very popular in Europe.
Yeah.
It's available in Iraq. Tablet
Sorry?
form. Tablet form. The labetalol, it's available in Iraq.
In a tablet form, yeah.
Yeah.
التابلت هو التابلت اللي نحكي على التابلت غير.
Yeah, it is available.
خلاص ليش ما تطلبوا? Why don't you give it to ladies? This is the thing. If it's available, because it's more effective.
Yeah. We are still stick to the old school.
Well, هي هاي الشغلة. Change your practice. You have to change your practice and move forward.
After this webinar, we are going to change.
Yes, absolutely.
Well, I'm glad.
Expensive, I don't know.
No, I think the fact that the labetalol is alpha blocker and beta blocker is a big advantage to you. And not only that, but you have a wide range of dosage up to about 2,000 something. And therefore, you have actually a very wide range of treatment.
And I just had a message from a colleague in Karbala. شو تقول والعباس ما عندنا لابيتالول. تقول والعباس ما عندنا لابيتالول. But there is no lابيتالول. I just had it just now on WhatsApp.
Maybe I tell you what, can I just comment on that, because I recently I actually prescribed labetalol to a lady in Iran, and it is not available, and therefore they brought it from Basra.
Yes.
Then Asino, do they do labetalol while they are here? Asino.
دكتور للاسف ما عندنا لابيتالول.
ليش
هو احتمال نحكي ويا الشركه اذا هو هيك يعني جايد لاين ريكومندد وفيرست لاين
ريكومندد.
فيري جود اوبورتونيتي. خلاص دكتور حيدر وخليه ببالك.
دي خطيه لانه الميثيل دوبا هواي اكو ريبورتس عليه يسوي فاتيج وديبرشن. هسه نسواننا ناقصين بلاوي انه بسوي لهم فاتيج وديبرشن يعني ما خطيه.
Yes, we have to go faster. Question to you, Dr. Ali, that a patient with chronic hypertension whose blood pressure less than 160/110 with or without antihypertensive treatment. Can discuss about delivery. Is it common
Delivery.
not to give treatment even if the blood pressure more than 150/100? You give her magnesium sulfate even if the blood pressure is stable and changing liver enzyme. These are different.
هو ايش قلنا احنا قلنا الكلينيكال جادجمنت، يعني هو الدكتور all of us with time we develop a judgment, certain judgment. يعني you look at the patient as a whole, you don't look at the figures of the bloods and the enzyme, you don't look at other things, you look all together. فهي to have 160/110 and she been on this all her life because she got essential hypertension and she deal with that comfortably with no much symptoms. She doesn't need to panic about this kind of patient because this patient, but she needs medication. You cannot ignore 110 diastolic. You cannot tell her, don't worry, just sleep all the night and you'll be fine. She needs medication, but at the same time, you don't need to panic and deliver her or give her on magnesium sulfate. Magnesium sulfates in severe preeclampsia, they are very particular. Severe preeclampsia or imminent eclampsia, اللي هي in summary the sick patient. Sick patient, you see it once and you know it. You cannot forget that patient because you see it once, definitely you see it once, and every time you go to see it again, you say, I remember that happened to that lady, I should act. And action means magnesium. Magnesium means plan for delivery. That's the way it goes. Do we make mistakes and wrong judgment? Yes, we do. We are human beings. We all been there. I've seen many cases. We panic, start magnesium. She is perfectly well. After 24 hours, يجي الconsultant يقول وقف المغنيسيوم, carry on. She can go home. I've seen it. I've done it. Sometimes you don't blame your colleague because they're panicking. They are under pressure. Probably there is another labor ward full of sick people, and they will like, I don't take any kind of risk with this lady. Better start magnesium. حتى ما يجون باكر الصبح يحجون علي. فأنت هاي السايكولوجي نعرفها. المقيم بالعراق والمقيم هنا نفس kind of pressure, same type of pressure. يعني they are under huge pressure on labor ward. But sometimes you don't blame them to panic. هم human beings. بس هو شنو? We learn from our bad judgments. We don't repeat bad judgment.
Yes. Another question, when a proteinuria disappear after delivery?
When does it disappear? هو proteinuria, what does it mean? Nephropathy. يعني if the preeclampsia, the primary pathology, the placenta delivered, the baby delivered, the pathology needs some time to clear from the body. So over the next 10 days, 5 days, 7 days, the kidney should regain its function and should not lose protein, unless there is a permanent damage happened to the kidney. Unless she had a pre-existing damage, like probably she had some glomerular, some nephropathy we didn't know about.
A question for Dr. Ali Mohsen. Why avoid dopamine near-term pregnancy?
Yes. In this regard, we have some facts about nitrofurantoin as a molecule. It is excreted from the blood to the urine and needs a good renal function. This is on one hand. On the other hand, it is contraindicated in G6PD deficiency, and there is a slight risk of hemolysis for the baby. But the thing that to be kept in mind when using nitrofurantoin, that the renal function should be good in order that there is no accumulation of nitrofurantoin in the plasma. And towards the last days of pregnancy, this might be slightly compromised. So it is better to avoid nitrofurantoin during the end of pregnancy. However, according to the NICE guideline itself that I referenced in my presentation, it mentions literally that there is a risk of hemolytic anemia when used towards the end of pregnancy.
Yeah. Another question, can we use nitrofurantoin in the first trimester?
Definitely yes.
Yeah. Dr. Ali Naqash, what are the indications of diuretics in a pregnancy?
There is no indication for diuretics in pregnancy. You should not use them because you're only going to make the condition worse. If it's a preeclampsia,
I think
yeah.
the only indication is pulmonary edema. If the patient developing pulmonary
edema. If you have a pulmonary edema, you can. Yeah.
Yeah. Again, these pulmonary edema, you're going to manage her in intensive care unit, in which your priority would be to deliver to her life, not the life of the baby. So if you get to that kind of scenario, you're already talking about the life of the woman, not the life of the baby. You got to the stage where you think this woman going to die. I need to save her life in order to move forward. So this is a different decision.
Another question, shall we prescribe aspirin for all patients at risk of hypertension from booking?
هذا الكويستشن لمن؟
I think for Dr. Rahim.
Can you repeat that?
Yeah, shall we prescribe aspirin for all patients?
There are indication to prescribe preeclampsia before we actually put her on aspirin from the beginning, or if she had a family history of any factor which might actually lead to thrombosis, we actually put them on aspirin. Or if she had an intrauterine IUGR, again, there's indication to put her on aspirin. Yeah. And of course, the NICE guideline actually mentioned that, the new one.
What if there is significant difference in the blood pressure measurement between the two arms?
That's a very good question, actually. You go by other symptoms. You remember when I mentioned that you should not rely on one parameter. You have to measure other parameters. You have the patient, you have the complaint of the patient, complaining about what? You have the blood pressure measurement, you have proteinuria, and you have hematological investigation, liver function, renal function. And all that collectively, you decide whether you are dealing with a preeclampsia or not.
How much time we can go ahead with the question and answer? I think according to the schedule, we over. Can we proceed a little bit more or not?
For how long, Ali? Because I have only 5 minutes.
Yes, I think we have a lot of questions. I think we should stop right now because the time has over. And it is a great pleasure for us to thank you all. And we thank our audience, and many thanks for Acino Company for designing and sponsoring this webinar. And Dr. Haider, do you have any words to be said?
Yeah, I would like just to thank Professor Ali and Professor Rahim. I don't know if they have a word before me. So to our guests, Dr. Rahim, Professor Rahim, Professor Ali. Do you have any talk to Professor Ali, Professor Rahim?
Oh, Ali Haider, thank you very much. I appreciate your input in the webinar, and I think this is a very great contribution to the education in Iraq, and it's a great pleasure actually to talk to Iraqi doctor through the webinar. And I think that's a very, very good method of continuation of learning. We are learning from you, we are learning from other people, and we wish to contribute to the development of a very healthy health system in Iraq. Thank you very much for your contribution.
حيدر عيني بس أنا برأيي نسويها regularly, maybe once a month, from now on. حكيت ويا رحيم ويا علي بهالخصوص، يعني ما عندهم مانع، فاحنا ما عندنا مانع والله في الحقيقة يعني. I mentioned more than once, I would like the audience to interact by voice. Leave the picture alone, at least by voice, probably because the one who asked the question, sometimes there is so many sub questions need to be asked as well, and the interaction can make things more lively. Now we know this Ramadan and يعني, there are issues, but outside Ramadan we are more free, and so make it once a month in a weekend or something like that, one kind of couple of hours, and then we learn from you and you learn from us and all that,
ان شاء الله دكتور، ان شاء الله. هو حقيقه يعني هي أثينو دائما supportive these webinars and any scientific meeting. ان شاء الله حتى اذا خلصت الازمه مال كوفيد 19 ان شاء الله تخلص عن قريب، ايضا حضراتكم يجوز تزورونا مره بالسنه، يعني نقدر مثل ما تفضلت حضرتك نكون مره كل شهر نسوي ميتينجز، يعني ريجولار ميتينج، واكيد أثينو تكون سبونسر لهذا الشيء. حضوركم طبعا حضور الدكتور علي والضيوف الكرام.
Thank you very much, Haidar.
Consultation, يعني, if you have difficult cases to discuss like that in an open environment, it would be nice, لأن high difficult cases, this is the one you learn from.
Yeah. Inshallah. Okay.
Yesterday I received several messages from our colleagues in Basra, and they are very happy about the yesterday webinar. They are encouraging carrying on and organizing more webinars in the future. And this is my great pleasure to organize such webinars and encouraging discussion and changing ideas between different doctors in different parts of the world, really. Thank you very much for everybody, and see you.
Thank you very much. Thank you very much. And in the end, I would like to thank our guests for their efforts and time during the past 2 days. We hope to meet you soon. And until next time from أثينو, stay safe and Ramadan Kareem. Shukran.
Bye bye.
Bye.
Bye bye. Bye.